just want to understand from the side of NHIF, how many cases do you receive every year in terms of people who are using your facility? And then part two of that question is how many patients are covered by NHIF?
Thank you very much. And to Citizen, I think so far the cases we've handled about 40,000 cases, which are split in the middle between those who have complex and those who have lower status of the cancer. And out of that, 200, I think, have accessed services outside the country, but the rest have been accessing services locally. Yes.
So when you have this NHIF cover, like how much of your treatment is covered in terms of money and the services that you go to seek at hospitals, whether private or public?
What we cover as NHIF is chemotherapy, radiotherapy, and of late, brachytherapy. I think the doctor here could have explained all that. Chemotherapy, the third one is brachytherapy. The doctor is
brachytherapy.
Yeah, the doctor here should be the expert, should explain all that. Yeah. Chemo we cover on two areas. Yeah. 6 sessions on the minor level to an amount of about 150,000, and to a deeper level to an amount of about 900,000.
So these are 6 sessions
the ceilings,
per month or per year?
No, it's about cycles, because you see we have to have a way to define it so that the practitioner also, we understand one another. There's a bit of science there. How I'm covering and what the doctor want to do with the patient, because also it's about treatment, it's about my model of payment, to make sure that the patient gets the best, and also to ensure that we can control whatever the doctors are doing. And we also have radiotherapy, which we cover to also at 3,600 per session. Depending on what has been prescribed. So it's an area which really...
So on radiotherapy it has no cap? Like how many times
we cap with the value.
Okay.
We have an upper ceiling of about, I think, 150,000 shillings, yeah. So it's an area which really has a lot of collaboration, because I hope the doctor has really explained that it's not a one-go zone that you enter and say this is what you're doing. It's a bit more complex than that, but our control on financing is to try and see how do we have a more defined way to interact with the providers. Like now we only have about four areas which are doing radiotherapy in the country. Yeah, so you see it's a bit limiting, and you know. Yeah.
And so this cover...
And we've tried even to negotiate with them and try to make them, but you know, they're saying, okay, our cost of input is really very high, including the initial setup and all that, you know. So it's not as easy as you may think, a walk-in area, and, you know, yeah.
So when you talk about this cover, is it just the usual contribution, or there is an addition once you realize that you are suffering from one of the cancers?
Yes, NHIF is a social health insurance. So you make your contributions, but treatment, it's you know, it's equitable. You are treated according to your ailment. Yeah.
Right. And Dr. Karagu, as you manage the National Cancer Institute, and you have these cases of people who are suffering from this and they're coming for treatment, one of the complaints that we have heard, especially from the counties, is that there are no sufficient centers for treatment. You'll see very long queues, whether on paper or physically, at the Kenyatta National Hospital, people trying to come and access that treatment. From your research and what you've been doing, do you think there's even with the government strategy to deal with this, can we say that we are safe in as far as handling these cases are concerned within our own facilities in the country?
Yeah, I would say we have we have some fairly good capacity locally, because our 2 national referral hospitals are able to provide comprehensive management for cancer cases. Well, I know Moi Teaching and Referral Hospital has a challenge in terms of being able to provide radiotherapy, but that is actually supposed to be sorted out by the end of this year, because actually there's a machine that is currently being shipped to Moi Teaching and Referral Hospital. So we should be able to have radiotherapy being provided in both Kenyatta National Hospital and Moi Teaching and Referral Hospital. The beauty about the NHIF cover is that it has, why we had such a long queue, particularly for radiotherapy, is because in the public sector, it was only available at Kenyatta National Hospital.
Right.
Now, since NHIF is able to, to reimburse, to pay for NHIF members, even across the private sector, where we have a bit more machines. In Nairobi alone, I think we have about eight radiotherapy machines outside the public sector. So that has, in a way, helped bridge that gap.
Right.
But we also realize that, in the spirit of universal healthcare, we need to decentralize care across this country. So we have been working towards that. And one of the things that you've done is, you see, for cancer, there are three main modalities. You'd say there's chemotherapy, there's radiotherapy, and there's surgical treatment, among others. But those three are the main, are the key ones. Right. So what you have tried to do is that as we build, our vision is actually to have at least 4 regional treatment outside the two referral hospitals, to have 4 others across the country, like one in Mombasa, one in Kisii, one in Nyeri, and one in Nakuru. So as we go towards that, what we have done in terms of phase 1 is to capacity build them to be able to provide chemotherapy. So patients don't have to come all the way to Kenyatta National Hospital to access chemotherapy. So they can get their chemotherapy, they can get their surgical intervention, because surgeons are fairly well distributed in this country. Now, when it comes down to the radiotherapy, now that's where for now we have, I would admit we have a challenge, because most of the service is actually available in Nairobi. So I would say there's some capacity, and it's actually growing. There's a lot of interest, both at the national level and the county level. So for me, I think there's a lot of hope for this country in terms of strengthening access to treatment for cancer. Yes. Right,
and Dr. Darsh, as we highlighted one of the slides that we had in terms of the causes of cancer, we saw that 5 to 10% they are attributed to genetic defects, and then 90 to 95% are environmental and lifestyle issues. When you receive these patients and you're able to assess them, I don't know whether you're able to really analyze their lifestyle, what is the predominant challenge that you would think predisposes them to contracting this ailment?
So one is obesity, lack of exercise. The other main thing is the infection, particularly the HIV, immunosuppression, that is making the cancer cases to rise. These are the main things I'm seeing.
Right.
So, yeah.
Right, and Mate Muthoni, one of the ways that doctors will tell you, and people dealing with the field, they will say that one of the ways to prevent yourself from that is through lifestyle change. I don't know, when you are going through your treatment, are there any lifestyle changes that you had to adapt to? And from someone who has been there, what would be your counsel to other Kenyans who may want to prevent themselves from being in the same situation?
Wow, that's a tricky one, because funny enough for me, I do not fall in the classic group of risk factors. We do not have family history. Well, I'm not obese, neither am I HIV positive.
Yes.
And I lived a fairly healthy, active kind of lifestyle. I would do my marathons. I would carry my food. I would not eat a lot of junk food, but I still got breast cancer. So it's not, and that's one thing that also kind of guilt trips you when you get your diagnosis, that I did something wrong. There is a percentage of cancers that just happen. Something environmental with the air, the fumes that we're taking in, something just goes wrong, and you end up finding yourself in a situation. So for me, even as I was getting my guidance on how to manage my condition, it was not anything that I was not already doing. It's just that now I was more conscious about what I'm putting on my plate. When you're told to have your plate, to have half of it is vegetables, very little starch, very little protein, I'm more conscious about what I put on my plate. I'm more conscious about how much water am I taking. I'm more conscious about, am I exercising? Because before then, it was just something that you just do because it's good to do. But then now it's more deliberate. it's more, you actually put thought into the process. And just based on like the complementary therapies, your mental health. Are you getting somebody to talk to when you're stressed, when you're panicky? Are you having a nutritionist to access to somebody to tell you how do you prepare your vegetables? Do you boil them for 5 hours, or do you just steam them and you get the nutritional value? Do you have somebody who you talk to when you're not feeling well and you still need to go to work? Just those channels which are not really mainstream treatment plans, the more of complementary therapies, have really helped me be able to just continue and do away with a lot of the painkillers, the anti-nauseas, all these other medication that you're given, which already have an impact on your liver and your kidney. So I've been able to just use food and diet and exercise to just more or less manage my condition.
And so far it's working well?
So far so good.
Were you under NHIF or you had your private medical cover?
I was actually one of the beneficiaries of NHIF. Because they launched the super cover in October 2016. I got my diagnosis in August 2016. So by the time I was coming in for my chemo, I did my chemotherapy on NHIF. I am still using NHIF now for my quarterly reviews, for my medication. Yeah, so yes, I am actually a beneficiary.
And how much of a top-up do you have to do from your...
It depends. It depends because then the tests are also custom made for your condition. It's not a one-size-fits-all. So depending on what the doctor has requested for, depending on what they're investigating, is it your bone density we're looking at this time round? Are we doing a CT scan? Then that is what now the pre-authorization form states, and then NHIF determines. So at times it can range between, depending on what it is, from 100% cover all the way to 80%, or so you top up depending. Yeah. Right,
and of course, shortly we'll be looking at the feedback, what you've been writing to us. That is on 22422, our SMS line, as well as tweeting us at Citizen TV Kenya, at Sam Gituku, at Joy Muthengi, and at Willis Raburu. The hashtag is Daybreak. But first of all, to talk to Geoffrey, as far as this supporting or the financing treatment for patients is concerned, I don't know how much of a cost is this, and is this sustainable as we speak?
Well, you see, NHIF is broader beyond cancer, because we cover so many other aspects, and is a contributory social health insurance scheme.
Yes.
And so far, what we are doing, it's affordable, it's manageable, and we are operating with a surplus. And of course, medical costs keep rising. So at some point, people will have to put in more. But so far, what we're doing is okay. I can actually project this to the next 5 years with our current contributions that we're able to sustain. For cancer, I think we've covered about 1.3 billion. For the last financial year. And for the other financial year, we did about 1.2 billion. And yeah, so it's manageable. We can, for the programs that we're giving now. But of course, costs keep rising. So in future,
people have to chip in some more.
People have to chip in
but of course,
but you see, you cannot compare the kind of contributions we ask and for like what she has gone through. It's really, some of these conditions are life-threatening, and unless you get care, unless you get somebody to intervene, then it really is a challenge and is a problem.
Okay, and I'm told you have a viewer writing to us. I just want to see how that goes. That is Abuga Eric is saying, please give us information on affordable cancer screening centers. I think we start with you from the National Cancer Institute. Where are these affordable cancer screening centers?
I think most of our county referral hospitals are able to provide the basic, the top 5 cancers I talked about, breast cancer, cervical cancer, prostate cancer. They're able to, they're able to provide that service. So for me, I would say, I would advise Kenyans to access services at the county referral hospitals. They'll be able to, and actually we have just, we're just about to finalize some national screening guidelines, so that, in the past, what we've had were more episodic, opportunistic, sort of not very well organized. So moving forward now, we'd want to have a national screening program so that it's very clear across the entire health system that these are the priority cancers to screen for. This is a procedure for screening and so forth. But as I said, I think they're accessible in most of our county referral hospitals.
Okay.
Yes.
And are there any activities that you have planned for this Cancer Month to really raise awareness and help people go through screening? Maybe we start with you, Dr. Adash.
Yeah, we are doing the breast cancer screening, breast and cervical cancer screening. At
Where is
our
that?
center, yeah. Yeah, MPSHA. MPSHA associated with the HCG-CCK Cancer Center. Yeah.
And just to put, October is not a cancer month. It's just a breast cancer month. The World Cancer Month is actually February 4th is when we recognize all cancers. October is just designated for breast cancer. You have other months that cater for colorectal, for your prostate, from childhood lymphomas. So every month actually has a specific cancer that they are acknowledging. It's just that for some reason, we all remember October month, and that is when you have all the packages. Like now I know MPSHA right now has a package for a pap smear and a mammogram at 2,700. Everybody just concentrates on one month. But among survivors and patients, we're always asking, what about the rest of the months? You have 11 months that everybody is silent, and then in 1 month, we all congregate like it's Christmas, and we have this one thing that we all concentrate on. And all media houses are calling you and asking you, let's do something about cancer. What about the other months?
That's true.
Yes.
There's a question coming in for NHIF, but just coming back to you, the National Cancer Center, in as far as what she just highlighted is concerned, that people need to be aware throughout the year. I don't know how much success we've made in as far as that is concerned. How many people are getting to go seek for these services and screening way in advance? Well,
I would say we are a bit challenged because of availability of resources. So what we have tried to do is we have tried to partner with the civil society organizations. We have the Kenya Network of Cancer Organizations. It's the umbrella body for all civil society groups dealing with cancer prevention in this country. So we have been using them. We have been using them as our conduits, or as because we have materials. We have developed patient education booklets. So we use those outlets to disseminate the message. That's the first thing. Second thing, we try to also use our community. We have people we call community health workers who work in the county. I mean, they're part of the health system. Right. So we use, working with the counties, we try to use them to pass a message because they're actually based at the household level. So that's a way of sensitizing people on the need to access service. So we are basically using the resources that are within our control. But in terms of like doing like large-scale campaigns, like billboards or mass media campaigns, that we have not been able because, of course, of issues around resources. All right. Yes.
Last two questions for NHIF. Let's see that. One is saying, Anonymous is saying, why should one go to NHIF offices to negotiate before the treatment? I'm not sure that is the position.
We already have a survivor here. So, no, it's depending on, could depend on the circumstances of that patient in case. And some treatment require pre-authorization.
So it's pre-authorization, not
yes,
negotiation.
Across all our branch offices. And it also depends on what is the nature.
Okay.
Yes, but as per se, I don't know. You have experienced the service. It's a good to go service.
I have experienced the service right across the board, and honestly can say when we started off with NHIF, it was as easy as getting the pre-authorization form where the oncologist fills in what condition you have and what treatment is needed. Then you have the hospital accounts department confirm the amounts. Then you walk into an NHIF office, and within 24 hours I would get my authorization done, and I would come in the following day for my treatment. That was before the fraud started checking in and everybody trying to make money out of this amazing scheme that was there. Right. So now it has become, the checks now have become more stringent, which you would expect. So now it's taking me on average about a week and a half. So yes, it takes time, but unless it's an emergency, like for me, I know I get my medication refilled every 3 months. So before the 3rd month gets there, I already start doing my pre-authorization forms much earlier.
So it's about also planning your
It's about
schedule.
planning, yes, but it also is not very, and I understand from a patient's point of view, it's not very convenient if I need an intervention tomorrow and I have to run around for signatures today.
Yes.
It will not happen.
Yes.
Yeah.
All right.
Yeah,
So
because you see, we need like to verify, is it an oncologist who is sending this patient? Because you can see the kind of amount that is available.
Yes.
It can be easily lucrative to anyone. So, and you know, there is a lot of issues around these medical issues, and you know, so there are a couple of checks which we have to do, because again, if we leave it, it's not easy. But then this is what we call in medical parlance elective treatment. Any elective treatment, you can plan for it,
Yes.
and get your things right and checked.
All right.
Emergency protocols, they are there, and we do not override
still
over
be handled.
emergency. They can be handled at an emergency, then everything else follows.
Okay.